My name is Kaylee. I'm a third-year medical student currently doing clinicals in the US. Today I'm going to walk you through what it's like to be a medical student in the ICU during COVID. So every day starts out with me waking up at 4:30 a.m., going to play with my dog, and then making coffee, or a lot of times I'd end up at Dunkin' Donuts getting a oatmeal milk drink just because it was more convenient. I usually don't have to get coffee in the morning for other rotations, but because it was so early, I just let myself get away with it for a little bit. So I have to leave my apartment by 5 so that I can get to the hospital by 5:45. I'm 23 years old, but for some reason, whenever I drive in the dark, I feel like I'm about to go on a field trip. So there's one moving train and one stop train, and I have no idea what to do. I'm already late. Okay. And then it's about a 15-minute walk to the actual ICU. 30 minutes late. Woo! So I try to make it there for the 6 a.m. handoff, and the handoff is basically just one group of residents talking to the other one. So like the night shift talking to the morning shift. So the night shift is from 6 p.m. to 6 a.m. and then the handoff is where they talk about everything that happened overnight. So they would just go through the list of the patients, and they would say, okay, this patient had no events overnight, or they crashed, or something like that. And then after the handoff was done, we would each, like all the medical students and residents, would start seeing their patients. So medical students usually have 1 or 2 patients at a time, and the ones that are your patients are the ones you probably admitted or you had seen before. So after we're done seeing our patients, I usually talk to the nurse and see what she says as well, and then I go ahead and put in a progress note. And a progress note mostly consists of anything that happened last night, and then how the patient's currently doing. Like if you do a physical exam, did they all of a sudden have a new symptom, or are they perfectly the same? And then at the end you'll say what the plan is for today and each problem that they have and how you're addressing each one. And then because we only had like 2 patients, we tended to have some free time in between the handoff and rounding. So in that time, I would try to just look up things on up-to-date that I would see in the patient, or really anything. And that tends to be kind of like my form of studying that I was using throughout my time at the ICU. Like I didn't really have a lot of time to study otherwise. So instead, I would just go on up-to-date, and every time I saw something I didn't know, like a medication or disease or something I just didn't feel 100% confident in, then I would look it up on up-to-date and familiarize myself with it. And then walking around, so when we just walk around, we would usually start at 8:30 depending on your attending. And walking rounds consisted of us having our WOWs, so our walking on workstation, something like that. So we had that, and we were walking around talking about each patient, go to each room. So there were about 20 patients in the ICU, and each one we would pull up their note, pull up their lab values, present it to the attending, decide what we're going to do for the day. Are we going to change anything? How are they doing? And then usually the attending would go see the patient too, check in on them, and just be informed about everything. And then a lot of times the walking rounds would be up until lunch. So you start at 8:30 and then you finish around lunchtime at 12. So then once the lunch was done, I would head up to the residence room. Sometimes you can just kind of hang around and wait until they call you, but I made sure to be there just in case they wanted to do something. And that's how I was able to assist in a lot of things. Like they do quite a bit of procedures there, not like procedures that you would kind of think of, but it's like putting in the lines. So there were 4 lines that we would put in. Like we would put in a midline, a line, a central line, and then I guess a quinton isn't really a line, but it's similar to the central line for dialysis. And they were all different, and they had a similar procedure for each one, but it had to be a doctor that did it, and it had to be sterile. And that was always very interesting to watch. They have to use an ultrasound to find the vein or artery that they're looking for, and then they go ahead and like go in there, and sometimes it can be so hard to get it, and it's a whole process to actually put in the line. And then some things that I would also kind of be part of was whenever someone needed to be intubated. So it was always a commotion. It was pretty controlled though. It was like a controlled chaos, because I feel like in the emergency room when someone needs to be intubated, it's a bit different than when they're in the ICU, because a lot of times you already are expecting that they're going to have to be intubated. That's kind of why they're in the ICU. And we also got to see extubations, which was really nice. So when they took the tube out, and we saw people with the trachs, we saw people with it down their mouth, their throat. So we would just try our best to assist the residents taking care of all of the patients. And then you could either leave at 4 o'clock or 6 o'clock. So if it was alternating usually. Like if you had another medical student there with you, then you guys would kind of alternate in between. Like, okay, I'll go home at 4, you go home at 6. So that was long call versus short call. So it's essentially 10 hours versus 12 hours that you would be there. But because I was so interested, I would stay until like 7 or 8. I'm interested in ICU, and also I just kind of wanted to experience our resident schedule for the week. So I was there 6 days a week, and I was there from like 6 to 8. Like I got there when the residents got there, and I left whenever the residents left, because I really just wanted like a taste of it. And then I would get home by like 8:30 and then shove food in my mouth and go to sleep. So now that I've kind of walked you through my day, I'm going to go ahead and tell you about some of my own experiences in the ICU and how we deal with the patients. So we had about 20 patients in total in the ICU, and about half of them, so 10, were COVID. So a lot of the COVID patients were there for about a month or two, and they weren't really changing in terms of how they were doing. And the main thing with COVID patients is that you're really just adjusting their sedation, and you're adjusting their vent status. So the 4 things that you can really adjust for a ventilator is the respiratory rate, the FiO2, so respiratory rate as in like how often they're breathing. Like you and I probably have a respiratory rate of like 16 on the regular. And then FiO2 is the supplemental oxygen that you're getting. And then you can control tidal volume, so how much your lungs actually fill up. And then the last one is PEEP, and that's a big one. So that's positive end expiratory pressure, and that's to keep the lungs expanded. So those would be the 4 things that they would adjust all the time. They would go up and down. They tried to make sure it was on the lowest possible, but sometimes you just had to give them a ton of oxygen and hope for the best. And then for sedation, it was a lot of propofol, ketamine, fentanyl, Versed, and you were just constantly adjusting that because you didn't want them to literally go through withdrawal if they get off of it, and you don't want to wreck their kidneys. And it's just interesting because you just really you were constantly just trying to put them up and down, up and down. And a lot of times when you would intubate them, they would suddenly crash, or if you extubate them, they'd suddenly crash. So it was definitely managing all of their sedations, because a lot of them will make their heart rate go super high, and then the other one makes their heart rate go super low. So it was all about finding the right spot. And then when you were assessing patients, you were looking at their arterial blood gas to kind of make sure that what's happening is working. And the big thing that you're looking at there is their PF ratio. So their PaO2 that you would see on the ABG, you would look at that, and then you compare it to how much oxygen you're giving them. And that ratio would tell you a lot about the patient. So if it was lower than 300, it was really bad. And that was really everyone. And the main things that doctors would look at when someone's diagnosed with COVID was their prognosis, essentially. And they have a lot of markers to see, like, okay, is this patient probably going to do well with COVID, or are they probably going to need to be in the ICU? So if you don't really care about values, then maybe skip ahead a little bit. But these are all the values that they would look at in order to determine how well a patient's probably going to do when they have COVID. So they look at CRP, that's kind of like that is an inflammatory marker. And if it was above 1, that was bad. They look at LDH, and if that was above 250, that's bad. They would look at ferritin, and that had to be lower than 500. It was bad if you had lymphopenia, so that's the white blood cells. If they were below 500, that's not great. Or thrombocytopenia, as in your platelets are too low. And that was especially bad because a lot of people are clotting. A lot of COVID patients have clots, like they're getting the DVTs and the PEs. And then you would also look for a prolonged PT. And APTT didn't really matter because it's kind of another marker of inflammation, which obviously they're inflamed, so you don't really pay attention to that one. And then you can also look at fibrinogen. And another thing that apparently 30% of people with COVID have been getting is a lupus anticoagulant. And that's an even more increased risk of getting clots. And then the PF ratio, of course, that's the one that I was saying earlier, is very important. So yeah, a lot of the COVID patients tended to be there for a while. And the residents were telling me about how whenever they first got there, like whenever they first started dealing with COVID, it was only like the 80-year-olds that ended up in the ICU. But as time went on, it was only the 80-year-olds, only the 70-year-olds, only the 60-year-olds. And when I was there, we had a ton of 30 and 40-year-olds. So it definitely has progressed. We had a 38-year-old, a 46-year-old, a 48-year-old. We really didn't have that many older patients. It was mostly younger. And a lot of them never were sick before. They don't have any comorbidities. They just had COVID, and they're on a mechanical ventilation because they can't support, their lungs are just too dead. And it was really interesting having two attendings because like we had one attending and then he had a break at during the weekend, and then another attending took over. And the first attending was so like evidence-based, so like when you think of a doctor, that's who you think of, like you can picture him in your mind. And then the other one was just so like cynical. He did everything very well, and he was so smart and knew exactly how to plan everything. But at the end, he was just kind of like, but they might die, like they're probably gonna die. And I'm sure that's true, and he's been doing critical care for a long time. But it's just so interesting, like the huge change. Like the other one was so hopeful, and the other one was like, okay, we're gonna do our best. And now I would like to talk about my patient who I loved with all of my heart. It was so amazing to see him get better. So he came in with seizures. He was having seizures because he has a history of glioblastoma multiforme. He's had it for 22 months. And the thing with seizures is that sometimes if you have them, you can't protect your airway. And if you can't protect your airway, you can't breathe. So he had to be mechanically ventilated, so they put the tube in him. And he was only there for like 2 days, or it was a little bit longer than that, but he only had the tube in his throat for a day or two. So once the seizures were well controlled and we knew that he would have no problem breathing, they extubated him. And so I saw him the day after, whenever he was extubated, and that was the first time I was able to talk to him, and he was just the most adorable person. Like I was like, okay, so this is the first time I'm meeting you, like, and being able to talk to you. And he was like, what happened? Like, he was so confused. He didn't know what was going on. And I told him, you were having seizures and now you're here. And he was like, why was I having seizures? I was like, well, you weren't taking your medication. I mean, yeah, that's what happens. And then he said, well, whose fault is that? And I said, you tell me. So then he goes and tries to point to his wife, but his wife isn't even there. He's just trying to blame someone. And then I was telling him, well, we had the EEG on him, so we knew whether or not he was having seizures or what was going on. And I told him, well, we got your seizures under control. You're on the right medications. That's really great. So the reason you were intubated was because of your seizures, but then we got your seizures under control, and now you're doing great. And after I said that, he was just smiling, and then he started like lifting up his hand with great effort, like his arm, and he was like looking at me, looking at his hand, looking at me, looking at his hand, and then he goes very slowly and carefully, just like pat on my back, and he's like just happy. he was just really happy that, you know, it was under control. He was happy that he understood what was going on, because I think he was just confused, because this was the next day and no one had really told him what happened to him. So I was happy that I was able to be that person, and it was just so heartwarming to see him like kind of relearn how to move his arm and just boop boop. So it was really nice and cute. And then the wife and then he said, "Can I have a milkshake? Tell my wife I want a milkshake," because she was coming. So I told him, "Well, it's 8:30 in the morning. I don't know if she'll be able to do that for you, but we'll see." And then the wife came, and she was just so nice. She was like, "Yeah, you were there whenever he was intubated, and you just had such a calming presence, and it was so nice of you to be with me. You know, you realized that I really needed someone, like another human, to be there for me." And she was just telling me, like, "I really hope you don't burn out. I want you to stay the same. I want you to be nice," and la la la. And then she took down my name and was like, "I'm gonna tell your boss." And I was like, "Well, I don't know who my boss is, but sure." And I was talking to the wife during walking around, so it was towards the end. Like, we had just seen like 19 other patients, and I saw her because we were towards the end, and I started talking to her. And then the attending saw me starting to talk to her, and then he started to leave because he wanted to see the last patient. And then the wife was still talking to me, and she was like, "Oh, I just love your energy." And then I could see the attending kind of looking from, like, not looking like this, but he was just standing outside of the door. And then whenever I was done talking to the wife, I walked into the room that the attending was in, and she was like, "Oh, are you done getting your aura cleanse and all that?" And I was like, you could just tell he was just having a little joke with me, but it was just funny. And I was like, "Well, I mean, at this point, being in the ICU for a week, I wouldn't mind having my aura cleanse. I've never had it before, but this seems like an appropriate time for it." And then another patient was just so interesting. I mean, she was just a young woman. She was 40. She had a history of well-controlled epilepsy, and she came in for stomach pain. And then she hadn't had seizures in years, but then she had a grand mal seizure, like a huge seizure. And so she didn't need to be intubated right away. She was still able to breathe throughout the seizures. But the next day, she desaturated. So you can tell by her oxygen saturation, she went from like 100 to like 50. So they were like, "Okay, we need to intubate right now." So they intubate her, and then they're like, "Okay, we need to," so as they're intubating her, they see the strawberry froth. Like, it's essentially just like a bunch of fluid and blood. That's usually indicative of pulmonary edema. So the attending knew right away, okay, this is pulmonary edema. We need to do something about this. We need to figure out why this happened. And they thought that it was due to the seizures. So then they did a chest x-ray. They saw, okay, this is definitely due to the seizures. This is definitely a pulmonary edema. But then they wanted to make sure to check on the heart as well, because who knows if it didn't have oxygen. It's just good to check on the heart. So they took something called the BNP, and that usually tells you a lot about the heart. Like, is it dying? Is it actively dying, basically? Is it going into failure? So they saw that value was high. So then they did an echo, and then they realized, which an echocardiogram to like look at the heart properly, and then they realized she had something called Takotsubo, and that's stress cardiomyopathy. And so that essentially means that she went from having a normal heart to all of a sudden having an ejection fraction of 25%, which that's very low. The normal person should be above like 55 and more. So she went from having a normal heart to a 25% ejection fraction heart, and it was just so interesting because I remember learning about Takotsubo in medical school, and it was literally called like the heartbreak disease. Like, you go through that when you have a heartbreak, like whenever your loved one dies. Like this is like the example that they used was whenever your loved one dies, and how the partner sometimes dies soon afterwards. Sometimes it's from that. Like, it's just the heartbreak disease. So yeah, that's my experience with the ICU. It was amazing. It really reaffirms the fact that I love critical care, especially neurocritical care, and those were kind of the patients that I would definitely deal with in neurocritical care, like the GBM, so glioblastoma multiforme, and then the seizures. Both of them, that's something that I probably deal with. And then people that are coming out of brain surgery, neurosurgery, those would be the patients I would see. And I loved every moment of it. So I feel like it just reassured me that that's exactly what I love. So we'll see how that goes. Thank you so much for watching. If you like videos like this that are fun and informative, make sure to subscribe and like this video if you want to see more, and comment below and say hi so I can go ahead and welcome you. I post at least a few times a month, so I hope to see you in the next video. Bye!